more than one speaker here today, and we're really we've been hoping that we could get some education regarding genetics and obviously all the overwhelming information in regards to these options of genetic screening. We get lots of questions from our patients about this, so we thought we would try to break this huge topic down into subtopics. So we're going to start with GI cancers and genetics of GI cancers for today, and hopefully at some point we could all integrate genetics around breast cancer, ovarian cancer in the future. So we'll start with this trend. So our two speakers today are Jeryl Erickson and Stephanie Wiryaman. And so Stephanie, you're in?
Yes, I am.
So Stephanie, her bachelor's degree in psychology from McGill University and completed her master's training at the University of Michigan Genetic Counseling Program. And Stephanie here at MNC for
a couple start.
And Jeryl has a very long background in outreach and science education and has been with the Cancer Risk and Prevention Center since 2015. She's taking over in the next segment, so we're going back and forth. Yeah, so obviously, as everybody knows, feel free to ask questions, and we'll just make sure our speakers repeat them so everybody can hear. So take it away. Thank you.
Great. So as mentioned, I'm Stephanie, and this is Jeryl, and we're genetic counselors at Cancer Risk and Prevention down in the Scarborough Outpatient Center. I'm talking to you today about cancer genetic risk assessment, specifically hereditary GI cancer. And so today is to start with some cancer and genetics, a basic overview, as well as just going over the process of testing as well. We'll answer the question, what is genetic counseling? And then the bulk of the presentation will be going through the overview of hereditary colorectal cancer syndromes, using case examples to display these, as well as provide some surveillance and management recommendations as well. And we'll finish up with a little summary of considerations for primary care providers. So to start with cancer and genetics, we know that all cancers have genetic origins. These mutations are what drive cancers to develop and to grow out of control. So we have to differentiate between somatic mutations and germline mutations. Mutations are those that occur in non-germline tissues, for example, the breast, colon, lung, blood cells, etc. These are not inherited. These are accumulated over one's lifetime, and with the accumulation of multiple, they can contribute to the uncontrolled growth of cancer. So these are considered sporadic cancers, which confers the majority of all cancers are sporadic, around 70 to 85% of all cancer. When we're talking about germline mutations, these are those that occur initially in eggs or sperm, as they are heritable, and once inherited, that mutation is in all of the cells in the body. That for hereditary cancer, this accounts for only 5 to 10% of all cancer cases that are hereditary in nature. This is Knudson's two-hit hypothesis, which kind of drives the field of cancer genetics. So when we think about sporadic cancers, we have 2 copies of every of these genes, and this cell would accumulate 2 mutations in both copies of that gene into a cancer cell and lead to those uncontrolled growth processes. So mutations are accumulated throughout our lifetime just as chance, through aging, through environmental exposures, infections, etc. And so it would take 2 mutations, so 2 time points of a mutation to develop into a cancer cell. With inherited cancer, that first mutation is already inherited, is already present in all of the cells in the body. So that cuts down the amount of mutations and that burden of mutations that needs to develop in order to transition into a cancer cell. And so this is why we see higher rates of cancer in these individuals who have these inherited mutations, as well as earlier ages of diagnosis for them, because they only need that 1 additional mutation in order to develop into a cancer.
So as Stephanie was just differentiating between somatic mutations and germline mutations, we also differentiate between tumor-based genetic testing and mutation for and genetic testing for germline mutations. So tumor-based genetic testing is basically various methods that are used to look specifically at tumor tissue or bodily fluid. It may be looking at tumor markers. It may be DNA sequencing. It may be looking for protein expression, as in the IHC testing in colon and uterine tumors. But it's primarily to help detect, diagnose, and manage some types of cancers. Limitations are that that information is specific to the tumor, but it may detect inherited risks that are unexpected. So looking specifically at tumor tissue, because a germline mutation is present in all of the cells, the tumor-based testing may also identify a tumor that is or a mutation that raises some concern about the possibility of an inherited risk. It may also, the tumor-based testing may detect a mutation that's not even going to influence the patient's medical management. Genetic testing, which is the bulk of what we will be talking to patients about when they come to us concerned about the possibility of an inherited cancer susceptibility disorder, is the DNA sequencing deletion duplication analysis of specific genes that are related to inherited cancer syndromes. It's done primarily to help us guide screening and management, not only for the patient, but potentially for other family members who may have the same genetic change. And risks, certainly with germline genetic testing as well. It's possible for us to look at every risk gene. There is the possibility of unclear or unexpected results if we're doing a panel-based testing. We may have a mutation in a gene that really wasn't on our radar screen, so to speak, and then we'll be addressing that. It's able to screen and prevent all cancer risks. So we may be identifying cancer risks in individuals that we don't have good surveillance for. This, of course, can provide some level of anxiety and distress in patients, and there's also the possibility of insurance discrimination. There's different approaches to genetic testing for inherited cancer. We can do what's called single-site testing. And when somebody in the family's already had genetic testing that's identified a specific genetic change, and we're going to look for that specific genetic change in other family members. Single testing, on the other hand, is looking at the entire sequence of one particular gene. This might be done if a patient is diagnosis of a particular condition, and so we're going to focus in on that particular gene. It might also be done if somebody in the family has a diagnosis, but they haven't had genetic testing, or we don't have copies of that genetic testing, so we focus on one particular gene within a family. Now, when we're seeing patients today, we're talking about multi-gene panel testing, looking at a spectrum of genes to see are mutations present in a family of genes that have similar associations to cancer risk. So multi-gene panel testing, as I already touched on, if you're looking at 15 or 20 different genes, you might be identifying a mutation in a gene that wasn't expected. Some of the cancer risks associated with particular genes are not yet well identified, particularly those in the more recently discovered genes. Negative results in an unaffected person don't mean anything as far as if they have a significant family history. So, history of colorectal cancer that's suspicious, but the patient has not had a cancer diagnosis. In fact, negative, we're still going to be recommending that they have increased surveillance and management because of their family history. Still haven't identified the cause for this cancer in the family. So even if their testing comes back negative, we're going to be still managing them based on their family history. There's also some pushback from the insurance companies, some of them regarding panel-based testing. Some of them feel like it's still experimental. So patients do sometimes have out-of-pocket costs for this. From the results that we can get when we do germline genetic testing, occasionally they come back with what we call a pathogenic or likely pathogenic variant that we would also refer to as a mutation. If this is the case, there's going to be increased levels of medical management based on the cancer risks linked to that gene where the mutation was detected. It's also to be recommended that family members have genetic testing because they are now at increased risk for this genetic change. So the time the testing comes back negative. These are rare, the inherited cancer susceptibility disorders. So even families where we would be suspicious, the testing often comes back negative. The other third possible test result is called a variant of uncertain significance. And for either of these results, it's impact medical management or surveillance. We're going to continue to manage that patient based on their family history. So uncertain results, same thing. They don't influence recommendations for medical management or care. Please.
As tumors themselves, that will be being to have more, do you think that will ultimately help to improve, just like outcomes with people having genetic testing? I mean, it seems like if you can identify something more clearly, it's more sensitive and specific to go in looking for one mutation as opposed to doing these panels.
Within the tumor, you mean?
I mean, I guess they have to understand it. They understand, though, is that the gene that is the problem? That seems like the challenge is knowing, like, is it multiple genes or is it one gene that's... Right.
So there are tumor-based testing that's going on now. And that's what the IHC universal screening of colon and endometrial, that's considered tumor-based testing. And in this case, that does help us sort of refine who of the colon and uterine affected cancer patients are likely to have Lynch syndrome. So that does help kind of determine who should now be referred to us and who maybe for whom it's less likely. It's still you still need to take into account family, because maybe people who have a colon or uterine cancer diagnosis, IHC testing is not suspicious, but their family history sure is. And so, or if their cancer is at a very young age, or they have polyps as well as a colon cancer. But some of the tumor-based testing is not particularly helpful because, as Stephanie said, genetics is responsible for all cancers. So there's going to be genetic mutations that are detected in cancer tumors. Most of them are unlikely to be due to a germline mutation. They're testing tumor, and they detect in there that there's a BRCA1 mutation. That has significance for that patient because we know about BRCA1 and germline mutations as well. Does that answer your question?
Yeah, it would strike me that as this is becoming common, people are going in having their tumors before they have treatment, that maybe sort of help us to find more people in the population that would.
Right. Yes, and I think that's true. But I think that also if a lot of the people that we see don't have a cancer diagnosis, they're coming to us because of their family history. And but yeah, definitely doing more tumor-based testing is another way of identifying people who may be increased risk for an inherited cancer susceptibility disorder. So thinking about the panel-based testing, and specifically about this result of variant of uncertain significance, because this can be a little confusing to patients. We're telling them it's not negative, but we're telling them it's not positive. And the rate can be about 15% in some of the larger panels, so they're not uncommon. As said, they don't provide any clinically useful information at this time. Recommendations are going to continue to be based on personal and family history. It is recommended to test family members because they don't know what this genetic change means. What we tell the patients is that the laboratories will reassess their data, because this is basically the problem. They don't have enough data or evidence today, particular change to say, is it contributing to cancer risk or not? So they reevaluate their data at least once a year. It's reclassified. In touch with us, with the genetic counselors, we will follow up with the patient and the referring provider and provide an updated report. 80% of the time, the VUSs are reclassified to benign, about 20% to positive. But we also ask the patients to check in with us on a yearly basis. It's sort of just a double check so that we can reach out to the laboratory and confirm to make us feel secure that we didn't miss an email, we didn't miss a communication. It's the genetic counselor who's no longer with us. to confirm that that variant has not been reclassified. All right. So to answer the question of what is genetic counseling and what are you getting your patients into when you send them to us, so in short, genetic counseling is the process of helping people understand and adapt to the medical, psychological, and familial implications of genetic contributions to disease, and this is from the National Society of Genetic Counselors. Basically, genetic counselors are specially trained medical professionals who can help with, we have specialized training in genetics, we specialize training in psychosocial counseling, and have kind of this bigger picture view of the family in addition to just the patient. So specific to cancer, we meet with patients and their families to discuss their personal and family histories of cancer, their risks of developing cancer. We talk to them about recommendations for appropriate screening and risk-reducing measures. We also can discuss, as I mentioned, with the psychosocial counseling, psychological implications relating to having this personal or family history of cancer, related to genetic testing and related to these risk-reducing measures as well. And we also do try to help promote communication between families, particularly when families aren't as communicative between each other regarding their cancer risks and getting other family members in for testing as well. So what patients can expect when they come to our clinic, we have two different models of consultation at the moment. So one version where there is an MD and a GC who both meet with the patient. We also have GC-only consults, these are mainly for patients who already have a familial mutation that's been identified, for patients who are connected with our breast care center mainly, or other specialties that are connected with us already. We will gather a detailed family and personal history. This is done pre-visit through a paper questionnaire and online questionnaire. We'll go through risk assessment, so we have several models that incorporate personal and family history, and we'll also go through the differential diagnosis of different inherited cancer predisposition syndromes based on all of these details we've gathered. We'll then start a discussion of genetic testing options, if appropriate, and also discuss best testing strategies for the family. Sometimes the patient who comes to us first isn't the best family member to test. Maybe else is still living and has a diagnosis of cancer. They're more likely to have this mutation than a family member. So we might suggest that family member come in for testing first. We facilitate this testing. It can be complicated with all of the different options in different companies right now, and so we help facilitate that process as well as the insurance process. A lot of insurance companies are also now requiring genetic counseling, and just has better understanding of how insurance works with genetics is helping patients. And we have our patients come back in for the disclosure of their results with management recommendations, whether it's positive, negative, or variant of uncertain significance. When we think about which patients are coming to us, we think about these hereditary red flags. So red flags that are making us think that the cancers in this family are more likely hereditary than they are sporadic. So one of the first ones is the young age of diagnosis, for example, breast cancer under the age of 45 or colon cancer under the age of 50. We'll look for rare types of cancer, including cancers like ovarian cancer, male breast cancer, pancreatic cancer, certain types of brain tumors, certain specific types of kidney tumors, things like that that are rare in the general population. We also look for people who have had multiple cancers in their lifetime. So 2 or more different cancers in the same person is another red flag to us that maybe there's something causing these increased risks for cancer. And lastly, we look at that family history to see 2 or more family members with same or related types of cancer. Some of the related types, for example, breast and ovarian, breast, sarcoma, and brain tumors, or colon, uterine, and ovarian cancers are some of those related tumors. So moving to hereditary colorectal cancer specifically, know, as I mentioned, that most cases of colorectal cancer are sporadic, but we do have this 10% that we know are hereditary or caused by a single genetic factor leading to the increased risks of these cancer. Of this hereditary portion, majority, so up to 4%, is comprised of Lynch syndrome, and we'll be going into more detail about each of these later. And then we also see these polyposis
associated syndromes, up to 1% for FAP and 1% for MAP. And there are other rare syndromes as well that are up to 4% as well. And we're thinking about patterns of inheritance in these genetic syndromes. We have two main models of inheritance in these cancer predisposition syndromes. The first is autosomal dominant. Autosomal meaning that this is affecting the autosomes instead of the sex chromosomes. And so dominating, you only need a change in one of the two copies of the gene in order to have this change. So in thinking about inheritance, if there is an affected parent, and assuming unaffected other, because again, these are rare syndromes, there's a 50% chance for each child to inherit that non-working copy of the gene with the mutation from the affected parent. 50% chance for each child to inherit that working copy and to not be affected. When we're thinking about autosomal recessive, and this is the minority of all these cancer predisposition syndromes, the majority of them are autosomal dominant. We're thinking of syndromes where you need to have both copies of that gene mutated in order to have this condition. We also see the carrier parents where they only have the one mutation. So if there are two carrier parents, there's a 1/4 chance that the child will inherit both working copies of the gene, a 2/4 chance or 1/2 chance that they'll inherit just one working copy of the gene and one non-working copy of the gene, being a carrier as well, and a 1/4 chance of inheriting both non-working copies of the gene to being affected. So signs of hereditary colorectal cancer, the main ones are we think of colorectal or uterine cancer diagnosed younger than 50, so again, age being that red flag. More than one cancer in the same person, again, that multiple cancers in the same person. When we see 10 or more colorectal polyps during one's lifetime, and these can be either adenomatous, hyperplastic, or hamartomatous polyps. Also looking again for that family history, so one or more first-degree relatives with a Lynch syndrome-associated cancer, and include cancers such as colorectal, uterine, ovarian, stomach, pancreatic, ureter and renal pelvis, biliary tract, brain, and or small intestine. We also, when we see 3+ relatives, so not just the first-degree relatives, but expanding to the larger family with these Lynch-associated cancers at any age, and also looking for multiple close family members, again, with similar cancers or related cancers. Important to think that when we're looking at these inherited syndromes, we are looking for the cancers to all be on the same side of the family. So we think about the lifetime colorectal cancer risk with these syndromes. This can be as high as up to 100% with some of the syndromes such as the polyposis genes. Some of the other ones can also have high risks such as YH and the Lynch syndrome genes. We do some more moderate penetrance of these genes that can range from 20 to 40%. And then, as Jerry mentioned, some of these newer genes, we know that there's elevated risk, but the clarification of exactly what that risk is still evolving in terms of knowledge as well. So there is a wide range of these colorectal cancer risks, but they can be fairly high for certain syndromes. So when we think about hereditary colon cancer, we divide them into two categories. The first is this non-polyposis colon cancer. This is colon cancer we expect to see family members diagnosed at young ages and multiple family members as well with colon cancer. And we'll then talk about polyposis colon cancer, which is associated with having many, many polyps in lifetime, and sometimes with multiple rare polyp types as well. So we'll start with the non-polyposis colorectal cancer syndrome. And so we'll start with our first case. So Rebecca is a 61-year-old female, and she has a recent diagnosis of colon cancer. Her family history is significant for a sister with a history of colon cancer at age 48, so that's red flag number 1, and uterine cancer at age 53. Again, cancers in the same person, another red flag. They did tumor testing on Rebecca's colon cancer, which showed abnormal IHC staining of the MSH2 protein, and we'll go into more detail on what that means as well. So this is the pedigree. You can see Rebecca with the arrow pointing towards her in a colon cancer diagnosis. Her sister Rosemary actually has 3 cancer diagnoses, including a breast cancer at age 40. Other than these 2 individuals in the family, there isn't much significant in this family history. Sometimes important to note that not all family members are aware of all of the cancer diagnoses in their family. They might not be aware of all the members and the details of their health as well. But clearly when we see a family history like this with a colon cancer, with a colon and uterine cancer, one of the first syndromes that we're thinking about is Lynch syndrome. So we have Lynch syndrome, also known as hereditary non-polyposis colorectal cancer syndrome. And so this is the most common cause of hereditary colon and hereditary uterine cancer. It's due to mutations in DNA mismatch repair genes. So this includes MLH1, MSH2, MSH6, PM2, and EpCAM. In families with Lynch syndrome, as I mentioned, we see early onset colon and uterine cancer. We see multiple generations of affected individuals, and we see families with colon, uterine, and other cancers, as mentioned before. So these are cancer risks for individuals with Lynch syndrome. MLH1 and MSH2 are the highest risk genes that we see. Some of the other ones do have lower risks associated with them. But the risk for colorectal cancer can be up to 82% in one's lifetime. Endometrial cancer for women up to 71% in their lifetime. Ovarian cancer is one that we see around up to 12% in lifetime. And there is a 50% chance of having a second cancer within 15 years of the initial diagnosis. Yes?
So, there's no relation to prostate cancer?
There is now. We are finding more associations with prostate cancer. It's one of those newer things that we have found associated with these genes. I believe it's for MLH1 and MSH2, there's about a 30% risk for prostate cancer with these two genes. Again, other cancers include the hepatobiliary tract, urinary tract, small bowel, brain, CNS, sebaceous neoplasms, and pancreatic cancer. And we tend to quote about a 1 to 9% risk for these cancers combined. So I mentioned, and as Jerry mentioned with the tumor screening, is that we now have universal tumor screening for Lynch syndrome for colorectal cancer tumors as well as uterine tumors. So most pathology for these tumors is being done for these proteins. And what they're doing is immunohistochemistry staining for 4 of the mismatched repair proteins associated with Lynch syndrome. And so if we see an absence of these proteins, that can be one factor. It could be due to other things, but it could also be due to this germline mutation. And that could be why there is the absence of these proteins. So it's one of the factors we're looking for when somebody comes in with a colorectal or uterine cancer diagnosis. So a patient had abnormal staining of the MSH2 gene. So this chart from the National Comprehensive Cancer Network can give the plausible etiologies of this. The red box, you can see the MSH2 screen was abnormal, and this suggests the possible etiologies could either be a germline MSH2, an EpCAM mutation, or it could be sporadic cancer as well. And so what happened with Rebecca's genetic testing is she came back negative for any germline mutations in the Lynch syndrome genes. The somatic, so they also did tumor-based sequencing of the tumor as well, and it showed one MSH2 somatic mutation, so just in the tumor, and that's the plausible explanation for why the IHC came back abnormal, was because there was this mutation. Still, the family history is significant for her sister, so her sister Rosemary was recommended to pursue genetic counseling and testing as well. And so Rosemary came back with a couple of different things. We'll be focusing on this SH6 mutation that she had, which does give her a diagnosis of Lynch syndrome. She also had a MUT-YH mutation, which is associated with MUT-YH-associated polyposis, which Jerry will be talking about later on. And she also had some VUSs that are unrelated. Treatment for Lynch syndrome is colonoscopy starting at age 20 to 25 years, or 2 to 5 years prior to the earliest colon cancer diagnosis in the family. For example, age 18 if father had colon cancer at age 23. And this is repeated every 1 to 2 years or based on findings. So if there are findings of polyps, they might consider doing them more frequently, or if there are no polyps, less frequently as well. For the gynecologic management, prophylactic hysterectomy and bilateral salpingo-oophorectomy can be considered by women after childbearing is complete. We encourage them to be educated regarding the symptoms for abnormal uterine bleeding as well, indications of uterine cancer. There's no clear evidence at this time to support routine endometrial cancer screening, and there's no data to support ovarian cancer screening as well. But annual office endometrial sampling is an option. We know it's a good diagnostic option for uterine cancer. And as everyone probably knows, the screening for ovarian cancer isn't great, but it can be considered as well at the clinician's discretion. These modalities haven't had enough evidence to show that they're sufficiently sensitive or specific for this recommendation. They're kind of all we have at this point in time. And this is why many women might actually consider having that prophylactic hysterectomy in BSO. In terms of these other cancers, again, there's no clear data to support surveillance for gastric and small bowel cancers. However, when we do see family histories of individuals with these cancers or individuals of Asian descent might be at increased risk, they must also consider surveillance for this, and this could include an endoscopy with visualization of the duodenum every 3 to 5 years, starting at age 40. For urothelial cancers, again, no clear evidence to support surveillance either. With a family history or with an MSH2 mutation specifically, these individuals might be at increased risk and consider their surveillance, which would include annual urinalysis starting at age 30 to 35. With the brain cancers, thinking about having that annual physical, including a neurologic exam every year starting at age 20 to 25. Switching.
On to think about the inherited polyposis colorectal cancer conditions, we would certainly recommend a patient who's had 20 or more lifetime adenomatous polyps, but really the recommendation for assessment is 10 or more, or multiple rare polyp types. So our first case, second presentation, Matthew was a 27-year-old male who presented with multiple polyps at age 26. He had 13 tubular adenomas and a hamartomatous polyp. He had presented with rectal bleeding and pain. He did provide us with his family history in advance, which was helpful to us. So we have Matthew with his 14 polyps, and family history of polyps. His father had polyps, but at age 52 he'd had less than 10, so not hugely suspicious for a polyposis condition. But Matthew also had a maternal half-uncle who had had a pancreas cancer at 25, so very young pancreas cancer. He died at 27. And then 2 other cancers that were less concerning, distant maternal relatives. So certainly, prior to seeing Matthew, some of the conditions that would be part of our differential would be a number of polyposis conditions to include both the classic and attenuated form of familial adenomatous polyposis, associated with mutations in the APC gene, classic familial adenomatous polyposis, their lifetime colorectal cancer risk, 90% by age 45. These patients typically present with hundreds to thousands of polyps. For upper GI cancers, osteomas, desmoids, thyroid cancers, brain cancers, hepatostoma in children. The attenuated form, also a high lifetime colorectal cancer risk, but not quite as high. Polyp patients still dramatic, but not quite as dramatic as it is in the classic form. And that we would give some consideration to MUT-YH-associated polyposis, or MAP. Changes in the MUT-YH gene, mutations in the MUT-YH gene. The polyp presentation more similar to the attenuated form of FAP, and colorectal cancer risk at 35 to 53%. 2 more rare inherited conditions that have polyposis as a feature. Put syndrome is associated with mutations in the STK11 gene, 1% lifetime colorectal cancer risk. So we're seeing hamartomatous polyps in Peutz-Jeghers syndrome. And also, because of that family history of pancreas cancer, this was a consideration. You can see pancreas cancer in Peutz-Jeghers individuals, as well as breast cancers and GI and gynecologic cancers. People who have Peutz-Jeghers syndrome often have mucocutaneous freckling. So very dark blue or black freckling around the lips and eyes. But this often fades in adolescence. So as an adult, you see the mucocutaneous freckling. And juvenile polyposis syndrome with mutations in the BMPR1A and MAD4 genes, so two different genes. So 68% colorectal cancer risk. Again, sort of that more intermediate polyp presentation. Cancers can also be associated with this. And people who have mutations in the SMAD4 gene also can have hereditary hemorrhagic telangiectasia. Certainly when Matthew came for his consultation, he brought his mother with him. Because she was able to provide some extended maternal family history that was significant. Oops, holy smokes. For colon cancer and polyps. Yeah. So she had spoken with her father, so Matthew's grandfather, and he told her that he had a sister who had had colon cancer diagnosed at 55. He had two other siblings who had polyps, and second cousins who were with extra polyps in their teens. And he said they have a condition called FAP. So that certainly made us suspicious. And we discussed Matthew his candidacy for genetic testing, and he elected to have a panel-based colorectal cancer panel. And he had a mutation in the APC gene and has familial adenomatous polyposis. It had very high penetrance for both colorectal cancer as well as adenomas, cancers of the gastrointestinal system, and this congenital hypertrophy of the retinal pigment epithelium, or CHRPE. It's a benign retinal finding. It just is hyperpigmented areas, some commented on by eye doctors. So we ask people if they ever had that mentioned on their eye exam. Attenuated form also significantly increased lifetime risk, fewer colonic adenomas, not so much associated with some of the other findings. It's to be associated with mutations. There seem to be some genotype-phenotype correlations. So people who have the attenuated form of the condition more often have mutations at the 5' and 3' end of the gene, or in particularly in exon 9. So for people who have the classic form of FAP, very early onset of colonoscopy. So too many conditions, susceptibility disorders, where we recommend genetic testing of children under the age of 18, because there really isn't that much we would be doing differently for them. But there's one condition where we would. So the classic familial adenomatous polyposis, because colonoscopies would be to start at such a young age, it is a condition where we would recommend genetic testing of children. These go to every year once polyps are found until a colectomy is planned. And colectomy is often necessary because of the very high polyp burden associated with this condition. Adjuvant surgery in people who have the classic form of FAP, they do need to have increased continued surveillance of the lower tract, depending on the type of surgery that's done. 6 to 12 months for a sigmoidoscopy. If there's some rectal tissue remaining, every 1 to 4 years if all the rectal tissue has been removed. Survey people who have the attenuated form, very similar, but the colonoscopies wouldn't start until the age of 18 to 20, only once polyps develop. And if a colectomy is necessary, it is considered if the polyp burden is so high that it can't be managed with colonoscopy. For both would include an upper endoscopy in the mid-20s, where rectal polyps are detected, whichever comes first, possibly ultrasound of the thyroid because of known associated thyroid cancer risks, CT scan or MRI, if there's only history of desmoid tumors, or if the location of the mutation in the gene is one that's associated with desmoid tumors. Our last case, Andrea is a 38-year-old woman with, she was referred by her primary care doctor because of her family history of colon cancer and colorectal polyps in her dad, as well as colon cancer in her paternal grandfather and great-grandfather. So certainly suspicious for a dominantly inherited cancer condition. She, her sister, one of her sisters had had colonoscopy with no polyps detected. So he has family history. And she mentioned that, yes, her dad had an early colon cancer diagnosis. She knew he had polyps, but she didn't know how many polyps he'd had. His brothers had had colonoscopies, no polyps detected for either of them, but his father and grandfather had had colon cancer. So her dad was still living, we shared with Andrea that her father would be the most informative family member to initiate genetic testing in this family and recommended that he come for an assessment. He was agreeable to that. He's 64 and that young colon cancer diagnosis at 23 when he shared with us that he had had hundreds of polyps through his lifetime. So a significant polyp history, and as we already talked about the rest of the family history. He came for genetic consultation and elected to have genetic testing for colorectal cancer risk, and surprisingly, he had the recessively inherited condition MUT-YH-associated polyposis because the family history was much more suspicious for a dominantly inherited condition. Recessive inherited colon polyp syndrome that Stephanie touched on, which means he inherited a single MUT-YH mutation from his mom and one from his dad. That his siblings also are at increased risk for this condition. It means his parents, who are no longer living, were obligate carriers. His daughters are also obligate heterozygotes because dad has mutations. He's going to pass at least one on to each of his children. In this condition, we typically see at least 15 polyps, but fewer than thousands. Presentation typically in the 50s, and he was much younger when he presented. Polyps helminthus, baby hyperplastic. And only 1 to 2% of the population is heterozygous for a single MUT-YH mutation. So we know the colorectal cancer risk for heterozygotes is increased, but exact risks at this point in time. So the thing is colonoscopy every 1 to 2 years, beginning in the late teens. Once a person develops polyps with the goal of removing all large polyps. If with MAP develops colon cancer or colon polyps are too numerous to remove during colonoscopy, they may need to consider colectomy. Endoscopy in the mid-20s to 30, or once the colorectal polyps are detected, and thyroid ultrasound again can be considered because of the risk of thyroid cancer. So the MH heterozygotes, because of course Andrea, our initial patient, is an obligate heterozygote, as are her 2 sisters. And then guidelines right now for MUT-YH heterozygotes are if they are unaffected by colorectal cancer and have a first-degree relative who's had a colon cancer diagnosis, they should their colonoscopy at age 40 or 10 years prior to the age of the first-degree relative's diagnosis and repeat every 5 years. But what we have is we don't yet have specific data to determine screening recommendations for a patient who is heterozygous for a MUT-YH mutation and a second-degree relative with colon cancer. Patients who don't have colon cancer and they have no family history, it's not certain that they even need increased surveillance at this point in time. This is an area where we anticipate likely learning more about this, so it's something that when we see patients who are heterozygous, it's important for them to stay in touch with us so that we can be updating them about this as they move forward. So Anne did come back. She understood once her father got his results. That meant, because she had already come and spoken with me, was heterozygous for this, and we had talked about the fact that given her dad's early diagnosis of colon cancer, important for her to continue to have increased surveillance, but certainly reassuring that she and one of her sisters does not have any polyps at this point in time in their 30s. We also talked with them, because though 3 of the sisters are still of childbearing age, the possibility that their partner might want to consider genetic testing for MUT-YH mutations because of its high frequency in the general population. If they and their partners both have a MUT-YH mutation, then they have a 1 in 4 risk for having a child with this YH-associated polyposis, and that would be important for them to be aware of. Just in summary, considerations for primary care physicians. Remember those red flags that Stephanie touched on. Young diagnoses of cancer, rare types of cancer, pancreas, ovarian, multiple cancers in a single individual, and family histories that are suspicious. And if you're not sure, please ask. We're happy to have you call us. We're happy to talk with you about it over the phone. Indications for referral. Most recent NCCN guidelines, any family history of pancreas cancer. That's a lot of people. So new pancreas cancer diagnoses are being sent our way. And oftentimes, of course, unfortunately, pancreatic-affected family members are no longer living. Important for their offspring, their descendants, to be made aware of possible risks. It's also a challenge because, of course, we don't have very good proven surveillance tools for pancreatic cancer at this point in time, but this is the most recent guideline that's just come from NCCN. Any history of gastric cancer at a young age or with a family history is another GI indication for referral. Also, with a copy of our most recent referral guidelines for all types of inherited cancer susceptibility. When is it refer, so we can have a more in-depth conversation. So that will be available to all of you. Remember that family histories are dynamic, they change. So if there's someone seen us, but then there's a new cancer diagnosis in the family, you consider sending them back for additional information and conversation. This changes a lot, so we're always encouraging you to stay in touch with us for any updates. Then the resources, of course, that we recommend are the National Comprehensive Cancer Network and Gene Reviews. So STAR 2 of the Board Genetic Counselors at Cancer Risk and Prevention, and by Dr. Miesfeld. Dr. Greatorex is also one of our physicians. Feel free to be in touch with us if you have questions. We're happy to talk with you about any concerns that you might have or your patients might have. So take any questions we might have time for. You're welcome. No, technically the NCCN guideline is first, second, or third, right, Steph? Family member, pancreas cancer. I think not necessarily a genetic test, and that's always important. It's important for your patients not to think they're coming to us for genetic testing, but for an assessment to really inform them so that they can, if genetic testing is indicated, know that, but mostly just to try and give them the information to go forward with. Because even though her dad may be deceased, maybe there's another family member who has a cancer diagnosis that's not pancreatic cancer, but maybe it's breast, or maybe it's ovarian, or maybe it's colon, and that family member might be more informative to start if they've not had genetic testing. Right. One of the genetic counselors said, I don't think you want to tell them that. And I said, well, that's what the NCCN guidelines say. I sort of feel like we have to tell them that.
Is that any kind of pancreatic cancer, even if it's like a rare type, like a asthma or a neuroendocrine?
Well, neuroendocrine, you've got to be thinking about a different inherited cancer susceptibility disorder, one of the multiple endocrine neoplasias.
So pancreatic cancer is all.
But typically pancreatic adenocarcinomas, but I mean, that guideline said any. Yeah, and I realized it's exactly as you said. That's potentially a lot of people. Yeah. So.
Thank you.
Okay. Thanks for coming and for inviting us.